And before we move to the South America speaker presentation, I want to introduce Luis Sakamoto. Lucas is our South America moderator and also a partner at Pine Biotech. And Lucas, if I can see you coming up on the screen here, there you are. No, there's still, there he is, there he is. We'll get you on the screen here. We're going to have you go ahead and come out and have you introduce omics training. It's all yours.
Thank you, Grant. Thank you all. First, I would like to thank the Academy and all the participants present here. It's with great honor that I would like to introduce and represent the participation of South America in this event. So I will share my screen with you all. Just a moment.
Lucas, you're muted at the moment. And we lost you. And we'll give Lucas a moment here to come back on. Dr. Sakamoto will be with you in just a minute. Oh, look, we're going to come to you early. It looks like Lucas has dropped out of Zoom. So we're going to go ahead and come to you, Luis, if you are ready for us. Well, let me see. We're trying to get him back in here. So give me just a minute, Luis. The fun of Zoom. Give us just a moment, please. All right, Luis, we're going to go ahead and pull the trigger here. I'm not seeing Lucas come back in, and we don't want to sag too long. So we're going to talk about precision. And we all know about being precise in language, or when measuring a board, measure twice, right? But precision is a relative thing. If we're going to the moon, we may measure in miles, and my woodworking is in fractions of an inch. But precision medicine and pediatric oncology is the specialty of our next speaker, Dr. Luis Sakamoto. Dr. Sakamoto is a medical doctor with more than 20 years of experience treating children and adolescents with cancer. God bless you, sir. His topic is the state of the art and perspectives relating to precision medicine and pediatric oncology. Luis, something tells me we're not going to be using my woodshop ruler.
Hello, hi everyone. Thanks for having me. Thanks for the organizer for the invitation to speak a little bit about my field, my work field, that is pediatric oncology. Well, I guess let me see if I can share my screen with you. Just a little bit. Okay. Let's see here. Are you seeing my screen?
Yes, we are. We can see your presentation just
okay.
fine. Thank you.
Okay. Okay. This is are the topic that we will talk about today. I will as I guess, I think there's few or even known attendants here that are used to deal with children with cancer. So I will bring you a little, a few informations about pediatric oncology, and in the second part, we will talk about how this bunch of information that is generated by the omics platforms are changing the way that we see the disease in children, and how we can use this technology to improve the efficacy of treatment, a efficacy that I will talk about this later, but a efficacy that is already really good when comparing to adulthood cancers. So let's go. Why I guess that there is no attendant here that is used to deal with children with cancer. It's because cancer is a rare event in childhood. In fact, when we compared the incidence of cancer in adults and in childhood, we can see that the numbers are very different, and we can conclude that cancer is a disease proper from older people. So it's really comprehensive, really understandable that there is no attendant here that used to deal with this type of disease. But the childhood cancer, although very rare, is in the high and middle income countries, is the second leading cause of death. In fact, cancer in childhood only only lost for the I'm sorry, just a minute. Oh, okay. In fact, cancer only lose for the accidents as a leading cause of death. And the major, the most common types of cancers are that are related to a hematopoietic system. So we have the leukemia that are the most common. In second place, lymphomas, and in the third place, the central nervous system's tumors. Although they are rare diseases, they are in the same way quite very curable diseases. If we see the evolution of treatment from the 1970s to 2010, we can see that there is a huge improvement in the efficacy of the treatment and a decrease in the mortality, especially for acute leukemias and brain lymphomas and brain cancer and lymphomas, especially non-Hodgkin and Hodgkin lymphomas. So this type of graph is it's a reason for all pediatric oncologists are very proud of this area of interest, because today we can cure a lot of more children than not cure. So why is it important to study this type of disease, given that we have a disease that is quite rare, and it's very curable? The fact is, when we are talking about a disease that's very curable, we have to think to give back this person, this child, to the workforce, to the society, to the workforce. And as shown as a recent study that's published in Lancet Oncology, we see that cancer in the childhood is a very common cause of disability and morbidity in adulthood. So we are cured a lot, but at what cost we are curing? In middle and low income countries, however, we can see that this evolution of efficacy of treatment is not as good as in high income countries. We can see, for example, that the USA, France, Australia, European countries are far away and a lot better in terms of efficacy of treatment than Latin America and East Asia, for example. We have a problem with low and middle income countries that, in fact, we don't know exactly how we are treating these patients, because we don't have a system of register of cancer that is really really good. And we can see in this graph that the proportion of patients that are covered by these registers of cancers are almost 100% in North America, but in Latin America, for example, it's only less than 20%. So we are curing less, and even those with are not cured. I mean, we don't know that why they are not being cured. As I shown before in that graphic that shown the evolution of efficacy in pediatric oncology, all that evolution was due the improvement of supportive care and conventional chemotherapy. None of that evolution was due the new technology that we have today. And in the past, when we treated, for example, a leukemia, an acute lymphoblastic leukemia, all we did when we are characterizing that disease is to see the morphological aspect of the cell and try to differentiate the cells from another kind of leukemic cells that are myeloid leukemia. So in that time, we have only the ability to differentiate myeloid cells from lymphoid cells. With the advent of the immunophenotyping, we had the capability to we were able to characterize more the cells in B cells or T cells, and to define subgroups of leukemic cells. And this is a methodology that is used nowadays to make the conventional diagnosis of leukemias. But with the advent of the new omics platforms, we are able, as you can see in this graph, we are able to define various subgroups of leukemic cells that have different clinical behaviors and different prognoses. For example, I would like to detail here this Philadelphia chromosome positive acute lymphoblastic leukemia that in the past has a really poor prognosis, but today with the advent of the tyrosine kinase inhibitors have a better prognosis, and with the advent of these omic platforms, we were able to identify a group of patients that are similar to this Philadelphia chromosome positive patients, but in fact they don't have this chromosome altered chromosome. We now are able to differentiate, for example, acute myeloid leukemia from adults, originated from adults, from acute myeloid leukemia from childhood. As you can see here, the target study that is performed in childhood, as compared to the TCGA that was performed in adulthoods, demonstrate that we have a bunch of alterations that are totally different when comparing children and adults. As well, the genes that are more prevalent as alterated in children are not almost never alterated in the adults, and vice versa. Study another type of neoplasms, that is medulloblastoma, that is a type of tumor that is quite common in childhood. It's originated from cerebellum in the fossa posterior of the cranium. In the past, we were able to classify only with the basis of histology, but nowadays with the advent of the omics platforms, we are able to define four groups of patients, four groups of tumors that has quite different prognostic probabilities. Just to know, WNT tumors have a survival rate that is are really higher when compared to the group 3, for example, that are the group that have the worst prognostic and the worst survival rates. Another utility that we have for this new technologies is when we have some kinds of drugs, target therapies that are specific to some kinds of gene alterations, and we want to see if that alteration indicates the use of a specific drug. But to do that, we have to know if that molecular alteration is an actionable target. And what is the actionable target? Is a alteration, genetic or epigenetic, that can be used as a diagnostic or prognostic tool, as well can be predict treatment response. There are a lot of schemas that to define this if the target is in fact actionable, and I will not talk about this right now. But in general, we define 4 tiers of 4 levels of importance to define if that target is actionable. And the Tier 1 is that variants that have strong clinical significance, and that alterations implies in the almost in the obligation of use of that specific drug. The Tier 2 is when we have a variant that have a potential clinical significance, but we don't have for example, FDA approved therapy for that. Tier 3 is that alterations that have unknown clinical significance, and Tier 4 is just alterations that are probably passengers alterations that have no significant clinical significance. I brought here a clinical case just for an example, a case of a male with 2 years old, patients with a diagnosis of neuroblastoma. That is a type of tumor that originates from the sympathetic system. It was performed a NGS study that demonstrates that this tumor has a mutation G26S in ALK gene, and the problem is to define if this alteration is clinically relevant or not, and if it's relevant, if this patient is a candidate to the use of ALK inhibitors. And we can nowadays we can make use of some platforms that are publicly available. One of them is from the St. Jude cloud, and what we see here is that in fact there is a description of this mutation in ALK that already have been described in patients with neuroblastoma, but we can see here that the alterations that were described in the ALK related to neuroblastoma are in other regions that are not this mutation that was found in our patient. And the classic R1275Q that is related to a ALK inhibitor response is far away from this alteration that was found in our patient. Just a second, let me just erase this. When we made a search in another databases, we found that these alterations have no has an uncertain significant clinical significance, and in the cosmic database we found no potential target therapy that could be used for this patient. So in this case, the finding of alteration in ALK G26S has no clinical significance